Good afternoon, everyone. I'll be talking about the aponeurotic variant of congenital ptosis. So upper eyelid ptosis can be broadly classified as congenital and acquired. The congenital variant is characterized by a dysgenetic levator with poor levator action, absent eyelid crease, and a lid lag and down gaze, as characterized by the pictures on the left side. Whereas the aponeurotic variant, which is a rarely described entity in literature, it is primarily a mechanical defect of the levator with good levator action, a superiorly displaced lid crease, and no eyelid lag in down gaze. It can be attributed to perinatal events. This entity was first described by Anderson et al. In 1978 and subsequently by Martin et al. In 12 patients in 1983. All these patients had the previously described features and were managed by levator reinsertion. Our study was a retrospective review of 26 consecutive patients. The congenital onset was corroborated with old photographs and history, and a complete preoperative evaluation was done with photographic documentation. The most important step for these patients was intraoperative identification of levator disinsertion. When the levator aponeurosis disinsert, it frequently has a rolled over configuration where the detached end rolls up and attaches to the septum as shown in the figure on the right side. The detached levator aponeurosis appears as a wide band which can be seen a few millimeters above the superior border of tarsus, heralded by bare conjunctival vessels which suddenly disappear. After the levator is identified and it's gently separated from the orbital septum. This figure shows the separated levator aponeurosis, which is simulated to be rolled over. This after unrolling. So we can see here that the detached edge was attached to the orbital septum superiorly, and in case if we do not unroll, we would be losing about 3 to 4 millimeters of levator aponeurosis, which will result in overcorrection and increased lid lag and down gaze. After the levator unrolling, the orbital septum is gently recessed over, and the medial horn is usually found to be laxer than the lateral horn. The levator reinsertion is guided by the amount of levator action and the amount of ptosis, and we intend to leave the upper eyelid 1 to 2 millimeters below the superior limbus. This is a small surgical video. The upper eyelid crease serves as the point of surgical incision marking. The eyelid is stabilized with 3 traction sutures and lid spatula. The skin incision is made with radiofrequency ablation. After the orbicularis dissection, the disinserted edge of the levator is identified, and it is gently dissected off and unrolled. We can see the muscular and the aponeurotic part of levator clearly here. Once the dissection is complete, cardinal sutures are passed through the mid-tarsus, 3 to 4 millimeter bite, with 6-0 Prolene double arm sutures, and the levator is reattached to the center of the tarsus. Similar sutures are passed obliquely, laterally, and medially. After that, the suture tightening is done, while monitoring the lid contour and lid height. The post-operative results were considered to be good if the symmetry between the margin reflex distance 1 was within 1 millimeter. In the figure, we can notice that the superiorly displaced eyelid margin, eyelid crease, was also corrected post-surgery. In our cohort, the mean age of the patient was 25 years, and the range was from 5 years to 37 years. 24 patients had unilateral ptosis, 2 had asymmetrical involvement, and birth history was positive in 2 patients. Majority had a good levator action of more than 8 millimeters. 3 patients had a pronounced lateral droop, which was corrected surgically. Intraoperatively, our findings were that 21 patients had a levator disinsertion, 1 had a dehiscence, and 4 had disinsertion with secondary fatty changes. These patients 21 patients underwent reinsertion of the levator, 1 needed plication, and 4 underwent advancement. 7 patients needed postoperative suture adjustment in the first postoperative week after the resolution of edema. All patients had good postoperative results with acceptable symmetry. As you can see in these pictures, the preoperative on the left side and postoperative images on the right side. The levator disinsertion is characterized by complete detachment of the aponeurosis. The vertical palpebral fissure is reduced in down gaze. The patients usually have a good levator action and can have a displaced lid crease, and they can be managed with LPS reinsertion. In contrast, the dehiscent variant will have a partial weakening with normal palpebral aperture in down gaze, good to excellent LPS action, and can be managed with LPS plication. Both of these can have a secondary fatty infiltration component, which can result in fair to good levator action. A lid lag may be seen in down gaze and can be managed with reinsertion, plication, or resection depending on the levator action. This flowchart summarizes what I've just said before. In comparison to the previous studies done, our study had 26 patients with good to excellent levator action, normal to raised lid crease, and were managed with exploration and reinsertion of the levator. All had good postoperative results without needing any resurgery. To conclude, congenital variant of aponeurotic ptosis is a less known entity. It is essential to differentiate from a dysgenetic ptosis clinically and to identify the disinserted levator and to unroll it before attaching. Surgical exploration of this defect and repair is a must. Thank you.